actually came to the inaugural Hope Island event in 2015, which Alex was also at with Kevin Fitzpatrick, and you know, we owe a debt to Kevin actually for starting this initiative. So I don't know, how do I move this on, or just press the button down, do I? Okie dokie. So Care Not Killing is a sort of coalition of different organisations. We're now set up as an organisation ourselves, but we were formed as an alliance of different organisations. Some hospices, some disability groups, some medical groups, and obviously some faith groups as well. But as I say, we've been going really since 2006, when the first bill was introduced into the UK Parliament by Lord Joffe. Since then we've seen numerous attempts, both at Westminster and in Scotland, also in Guernsey, to change the law, and all of those attempts have failed. And the reason all those attempts have failed is because when people think about this issue, and they're initially perhaps sympathetic, and they think about the complications that arise and the dangers that arise and the difficulties in controlling it once you change the law, those people who are open-minded tend to come down in opposition. So it's important, I think, first of all, to have some clear understanding of what we're talking about. And the first terminology is voluntary euthanasia, which is terminating someone's life at their own request. Then we have involuntary euthanasia, where someone's life is terminated and they've not made any such request. And then non-voluntary euthanasia, where their life is terminated, often by a doctor, but not necessarily, and they're not competent to make that request. And then there is assisted suicide, where one person is involved in assisting someone else to commit suicide. Now, of course, all these criteria are now often referred to in a very euphemistic and vague way of assisted dying, particularly in the UK press. And that's a very intentional thing by those campaigners who want to see a change in the law in order to make the pill easier to swallow, if you pardon the analogy. It's to make it society and politicians more receptive. But this is what we are referring to in practice. Now, there are two key issues, I think, that feature in this debate. And really, it boils down to a debate between a belief in the primacy of individual autonomy versus public safety. And so our opponents are largely coming from a perspective, or those campaigners for a change in the law, of belief in individual autonomy. Now, of course, they present their case in terms of pain and suffering, but actually what drives them is this belief, this absolute belief, or belief in absolute individual autonomy, which we were just hearing about there. Now, the right to decide when one's life should end and assistance should be given, particularly if the terminology of intolerable suffering is used, it's important to understand that that's an extremely subjective concept. It's very difficult for the law or for medical practitioners to measure whether somebody's suffering is intolerable or not. All you can do is go on what you're told by the patient. Secondly, that leads to value judgments being made by third parties about the quality of life of people with disabilities or people who are chronically or terminally ill. And so we then end up with other people making decisions on your behalf. Many people, perhaps 25% or more with a terminal illness, will also have clinical depression. So then the question is, are they getting that depression treated? Now, in Oregon, only about 1% of assisted suicide cases are actually referred for psychiatric evaluation prior to the death occurring. And of course, elder abuse is on the increase. So the World Health Organization, for example, estimates that 16.6% of people aged over 60 have, in the past 12 months, experienced some sort of abuse. So these all limit autonomy, even although autonomy is the premise upon which advocates are wanting a change in the law. Then there's the issue of protecting the vulnerable of our public safety. So what we have seen happen in some jurisdictions, particularly in the Netherlands, is that we see involuntary euthanasia, non-voluntary euthanasia, and continuous deep sedation, and Belgium as well, becoming frequent practice. Now, these countries are at the forefront of the move towards euthanasia. They were the outliers, really. But nevertheless, that's the case. We see physician-assisted suicide and euthanasia are far cheaper than providing health and social care. So, for example, there were a couple of Scottish academics who wrote a paper in 2020 in which they described savings in healthcare costs and increased organs available for donation as the elephant in the room in the debate. Now, they weren't suggesting that this was a reason to change the law, but what they were saying was it's a factor in the debate that needs to be considered. And of course, everybody was horrified that they should say that. The proponents of a change in the law and ourselves all said that's really lowering the tone, etc. But it's interesting that they felt confident enough to say that. Individuals and families are also tempted by financial pressures and costs. So, for example, Marie Curie in the UK estimate that the additional cost of living with a terminal illness is between £12,000 and £16,000 a year. And of course, care home costs might be £1,500 a week. So there are very high costs in living with terminal or chronic illness. And these costs are not considered in the debate, but it is perhaps something that we should be willing to face up to, that it's not just an issue of how much does it cost to go to Dignitas, which is often cited in the press, but rather that the pressures that people will feel under because of their own care costs, which will force them into this. And of course, as Alex will talk about later, poverty and lack of ability to live is increasingly driving people in Canada to assisted suicide or euthanasia. So the question then is, how do we respond to that? Is helping people to kill themselves the appropriate response, or should we be looking at the level of support that we have for people with terminal illness or disability? And obviously Marie Curie and other hospice charities are campaigning in the UK for increased support for people in those conditions. And then fear of being a burden is increasingly cited as a reason why people cite for seeking an assisted suicide. In Oregon, it's been over 50% on average in recent years. And then loneliness is another reason that people cite for seeking an assisted suicide. All these factors are not issues that cannot be addressed in other ways. But increasingly, death is being offered as a solution to these social problems. So the slippery slope is inevitable. We see it has moved from people who are terminally ill to people who are chronically ill, from adults to children, from mentally competent adults to mentally incompetent, from those with serious illnesses to those who have multiple minor conditions and are just tired of life, as is happening in Belgium illegally and is being proposed in the Netherlands. We see increasing numbers of deaths in all the jurisdictions with no plateauing, no levelling off. We see that the proposed safeguards don't work. They're then seen as discriminatory, they don't last, and they aren't safe. We see that conscientious objection rights of medical staff are removed or watered down, and increasingly it's becoming evident that suicide prevention strategies are undermined, with some people's lives being considered to be of more value and more worth than other people's lives. In the UK and Channel Islands and Isle of Man, current proposals are both for people with terminal illness in Jersey and chronic illness, although there has been an ethics review and it may be that the chronic illness route 2 will be dropped, but that's not currently the case. We see that in Scotland, for example, that no prognosis of death is required, so doctors are allowed to so somebody might have 5 years to live but still qualify for an assisted suicide death. Doctors can intervene if things don't work out, which is the case in 7 to 9% of cases. So is that euthanasia or is it not euthanasia? That's unclear. That's not been made clear what's being proposed, but I think we can assume that what's being proposed is some sort of informal euthanasia system without it being specified in law. Doctors and healthcare staff are conscientiously objecting, would have a duty to refer to other practitioners who would facilitate the death, so that then impinges upon some people's consciences and likely to drive them out of the profession. Palliative care doctors, 42% of palliative care doctors in Scotland said that they would consider leaving the profession if this was introduced in their hospices. And you should remember that there are fewer palliative care doctors in Scotland than there are members of the Scottish Parliament. So we're not talking about a huge number of people who provide specialist palliative care services, So if you lose 42% of them, or even 10% of them, then that's going to have a diametric and dramatic impact upon end-of-life care for everybody. Hospices and care homes won't be able to opt out, so they'll be forced to do it, which might mean that some of them will end up closing. Online consultations are being proposed, so the doctor doesn't even need to see the patient in person. How he will detect coercion in that circumstance is open. I don't understand how you can do that. It's difficult enough to detect coercion, but if you're not actually sitting with the person. There's no requirement for a psychiatric assessment, only an option. 2 doctors sign off with perhaps only 1 year's postgraduate experience. So we're talking about very junior doctors being allowed to do this. And doctors can raise the subject of euthanasia and assisted suicide. And indeed, even under current GMC guidance, arguably, if it's considered to be medical treatment or a healthcare option, then they would be under a duty to do so. And then any law is likely to be subject to equality challenges in the courts, not least because of this issue about euthanasia and whether people can self-administer, etc. What do we see happening in all the jurisdictions where the law has changed? Well, as I said, there is a continuous upward increase in the death rate with very little sign of a plateauing occurring. This is because, in my view, assisted suicide and euthanasia become normalised in society, and it becomes seen as an appropriate treatment option to intractable diseases. So in Belgium, when the law was introduced, it was claimed it would only be for exceptional cases, but as you can see, over time the numbers have increased dramatically. In Belgium, we also have seen a considerable number of deaths where there has been no explicit consent given. So 1.7% of deaths in the Netherlands are where the death has been hastened by the doctor intentionally without any explicit request from the patient. And of course, you've got to remember that part of the reason that the law was changed in Belgium was to address the issue of lack of transparency. So if you then have doctors hastening death with intentionally hastening death without consent or having been given, now that may well be because the patient's unable to give consent, but nevertheless, you then have to say, well, where's this issue of transparency then if it's not being officially recorded in the statistics? Belgium, there was a report recently came out a couple of years ago, 2021. This was one of the first major reports, sort of an audit really of the Belgian system, and they said that they had 3 conclusions. One was that that physicians can diagnose polypathology, which is an assortment of minor medical conditions, as sufficient criteria for euthanasia. Now, of course, that's not what the Belgian law says, but that's what's happening according to this report by Rouse and his colleagues. The treating physician can override the objections from doctors who have been brought in to give second opinions. And then the Oversight Commission, which monitors euthanasia, has conflicts of interest. And we actually intervened in the only case that's gone before the European Court of Human Rights where a breach of the right to life was found, where part of our argument was that there was a conflict of interest in the doctor who performed the euthanasia because he sat on this Oversight Commission. Part of the reason why the Article 2 breach was found was because he was sitting in the room when they were discussing, or at least it would appear that he may have been sitting in the room when they were discussing the case.